Good morning. Good morning. Welcome. Welcome to this session. Thank you for choosing to join us on a very busy WHS morning. My name is Caroline Bindio. I am the Chief Innovation Officer at AMREF Health Africa, and I'll be your moderator for this session. I spent the early years of my career in the private sector. And when I joined the nonprofit sector, I needed to learn many, many new things. And one of the early reports that I read as in my career was from the Gates Foundation. And that story stuck with me. And it was a report on a project that was working in food security. And what that project was trying to do is ask how they can use different variants of seeds to support food security in a particular community. So what the project did, they went into that community, they spoke to the farmers, and they asked the farmers, what kind of seed would you like? What would you prioritize when you're selecting seeds? And the farmers overwhelmingly said yield. They would like more yield from the seeds that they're collecting. So they brought a new variant that had more yield, planted it, it grew, was harvested, and it successfully provided more yield for these farmers. But strangely enough, the neighbors, the community, did not take up that seed. And they wondered what happened. We spoke to the farmers, they told us what they wanted, we have given them what they asked for, yet we are not seeing any improvement, any adoption of this new technology in this community. So they went back to the community and they spoke to more people. And what they realized is that when they went to speak to the farmers, their criteria for selecting farmers was who owns land. And who owns land? The men. So they spoke to the men and they asked the men about what they would like to see from the yield. So they went and spoke to the women. And the women had completely different priorities. The questions they were asking is, how long does it take to prepare the land? How often do we have to weed? How long does it take to cook once we harvest? And what does it taste like? So the priorities of the women were not considered. And the women, this was their priority because this is the work that they do. They till the land, they weed, they cook, and they serve food to their families. And why this story stuck with me is it really brings me to our topic of today. From data to innovation, how health data can transform global healthcare if we let it. Yeah. And today we see that health systems worldwide generate vast amounts of data, vast amounts of health data, including personal data, imaging data, genomic data, data from medical devices. Yet last year, the World Economic Forum report estimated that up to 97% of health data is not used. Up to 97% of health data is not used. I don't know if I understand what that statistic means. Is up to 97% meaning that some facilities use it, some don't, some institutions use it, some don't. Most of the data is used sometimes. I don't know what that statistic means. But it speaks to an urgency to discuss health data, the use of health data, and how that use can translate to positive health outcomes. I would say for me, this statistic encourages us to imagine what is possible when we use the vast amounts of data that we have. When we think about this farming community and the data that they collected, how do we ensure that we are collecting the right types of data and using that data to make the right decisions? To help me discuss what the barriers are what some of the breakthroughs are, what bold opportunities stand ahead of us, I would like to invite a panel of experts to join me to have this discussion, beginning with Dr. Bernd Ohensorge, who is the President, Middle East, Africa for Siemens Healthineers. I would like to invite Rutendo Kuwana from the WHO. I would like to invite Minister Rakan Nesaldin from Lebanon, Professor Heyo Kroma, who is the CEO at Charité, and Dr. Bettina Lundgren, Director at the Danish National Genome Center. So this morning, we are going to take a little bit of a different format. I'm going to ask each of our discussants to give some remarks on this topic, particularly focused on the work that they are doing. I will begin with Dr. Bernd from Siemens Healthineers. Siemens Healthineers is famous for medical technologies, imaging, diagnostics, point-of-care equipment. Can you tell us a little bit about the value of health data that is generated from medical devices, from a medtech person's point of view?
So with pleasure, and I hope my microphone works. I almost destroyed it with sitting down. So now I know why a tech check is needed, also for sitting down. So thank you. Also thank you for your interest. Thank you to all the panelists for joining. I mean, I'm really thrilled to see also this diversity in combination from leading academia in Germany, from Denmark, who are leading the way in Europe of digitalization, and also from the representatives from the emerging countries. And it shows that how important the exchanges, the cross-connection and know-how exchange, because how data can drive innovation and ultimately improve patient outcomes. I mean, it's a common opportunity and challenge. You might ask, why are we having in the year 2025 a panel on how can data help with innovation? Because I mean, yes, this future we should think and believe is already around us, and in a way it is. What is maybe limited yet is how to capture the progress, because, and this is why, I mean, I looked at the title, From Data to Innovation, how can it transform global healthcare? If we let it, maybe this let it is one dimension, if we lead it might be another dimension, how to make sure we think from the endpoint of where do we want data and AI to contribute value, and think backwards, what innovation do we need, and then think what data do we need in order to make that innovation happen. So this maybe as a bit of an opening understanding, and just yesterday our CEO of Siemens Healthineers, Ben Montag, said, well, do we have a data strategy at Siemens Healthineers? Not really. We have a healthcare AI strategy, how it impacts the elements that are important to us. And what are those elements? They are that we want to make medicine more precise along the fields we serve, and especially around the non-communicable diseases of cancer, heart and vascular disease, stroke, and neurodegenerative disease. So more precision in guidance through AI, at the same time, more efficiency in the system through AI. Because, I mean, we all know, I mean, demand is ever growing by a growing and aging population, at the same time also by new demands, like, I mean, prevention was discussed a lot yesterday, that will, for all the right reasons, increase further demand. So how can healthcare AI help to manage that demand, increase efficiency, and provide an increase of access to advanced technology to basically fill the gap of human resources that will never exist? So where healthcare AI and technology will need to step in. So this is basically in broad how we think where medical technology, especially technology that Siemens Healthineers is into in imaging, in laboratory diagnostics, and in image-guided therapy, things through it and how can contribute. And again, maybe this thought processes. Is it now a self-propelled process that we just let go and let it? Or shouldn't we look at thinking, what do we want to make a difference in, clinically or in terms of accessibility of healthcare delivery, and then think backwards. And how do we deliver the right data with the right quality in order to develop innovation that help fix that challenge? So maybe a bit more directed process is something that moves us.
Let me just press on what you said about starting with the end in mind and thinking about what do we want to achieve. Once these technologies are available, I think the end game is to ask, how do we increase access to diagnosis, which means that these technologies need to reach the places where they will make the most difference. What role does data play in helping to get there?
So again, I've been along that thinking from the end. I mean, now can get very concrete of what is Siemens Healthineers working on and moving about. It's in the example of imaging or laboratory diagnosis. How can we automate the process? How can we automate scanning much more? How do we need much less workforce also for complicated exams, so that the limited workforce can be used very efficiently, because the technology is in a way automated, and that is AI, that organ models are in, that patients almost can do, if regulations would allow, a self-service scan, because the machine knows where to find the heart, where to find the pelvis. It doesn't need much rocket science other than a reasonably allowed image of the patient. So how can we automate scanning? At the same time, how can we increase efficiency and have AI-based diagnosis? Mm-hmm. Both in rule out as well as in identification of potentially dangerous lesions. Mm. That is in the making, how radiologists are being supported by this. And thirdly, how can we make the interchange of diagnostic information as well as personalized therapy more AI-enabled and more accurate? Cancer care is a great example. Cardiovascular cardiac care is another great example, where the image data and laboratory data generated, AI will help to make suggestions how to treat, how to prepare an intervention. And these are things where you make a difference in outcome, and you can very directly look for how can we collect curated data around these situations to train the AI.
Mm-hmm. So, Minister Rakan, what Bernd says, it sounds futuristic, but we know that much of it is happening today. Yeah. You are coming from Lebanon, a country that is in crisis, and I think there is a need to balance between how do you manage the crisis, but also how do you provide medical services, and how do you collect data that enables you to provide medical services. Can you tell us a little bit about how you're managing it?
Well, thank you for the question and for giving me the opportunity to talk about my homeland country. Basically, Lebanon has passed through difficult times over complex crises, complex in terms of medical, financial, war zone, and despite all these challenges, we were able to benefit from the opportunity of data. As you know, if you plan your decisions based on solid background, which is data, and without data, the response is blind. For that, we have launched the National Digital Health Strategy 2025-2030, despite being in crisis. Which means that we identified first our problems, and then accordingly, we used the data for solutions. Mm-hmm. In terms of pharmaceutical problems, we managed to, we checked what are our main problems. We recognized that subsidized medications are leaking out. So we decided to do tracking. Mm-hmm. And accordingly, we use data for MediTrack. Also, during COVID problem, we had a problem with identifying patients that are prioritized to get the vaccine. And we had the platform accordingly to manage the vaccination process. Also, We recognize that we are at an area of pandemics, not only COVID, also we had cases of cholera. Accordingly, we improved our DHIS system and we expanded, and the response is faster and quicker. We had cases of cholera 2 years ago and the pathogen was treated in a couple of weeks. Also during wartime, you have the problem of displaced people, internal displacement, at the same time evacuating casualties and try to allocate patients to different dialysis centers, to PHCs, to new hospitals. And accordingly, also we improved our public health emergency operating centers using data and how to manage that while in crisis. So what my message is that despite being in crisis, we should benefit from data to do a proper response. Otherwise, the system will crash. So this is how we can go from data to innovation, in brief.
I have a follow-up question from you. First of all, I come from Africa, and Africa is low and middle-income countries. One of the things that we see coming out of Africa is a lot of innovation because, of course, we have a lot of problems that we are trying to solve. And I wonder if that is something that you see in the case of Lebanon. Do you have a lot of innovation coming out of Lebanon trying to address the health challenges? And how does data drive the innovations that are coming out of Lebanon?
Well, that's definitely so important. As you mentioned, we share the same economical burden. We are a low middle income country, and we, as I mentioned, we are relying on data for that. And this is the core of our strategy. We're not talking about AI strategy here. We're talking more about basic strategy, digital health transformation strategy. And this carries a lot of innovation. We are benefiting from the opportunity of academia and our partners, international partners, WHO, UNICEF, all international partners that are helping us formulating this strategy. And we're trying to put it in a context that benefits the country and benefits the needs, not for self-oriented or economical or company-oriented plan. So, as I said, we identified the needs, we are using data, and accordingly we're finding solutions. And this is reflected now, currently, by our expansion of protocols that we're using. Now more patients are being covered by the Ministry of Health. Yes, yet we don't have the universal health coverage that we're looking for, but at the same time, our budget is limited, and you need to do your cost-effective plans accordingly. According to what? According to data. Who's the most vulnerable people? Who are the most vulnerable people? Who are the poorest of the poor?
Yeah.
And accordingly, we have what we name the Aman, or safety system, where we use the data to benefit and to disperse medications and cover at hospitalizations.
I think that is a good place for me to come to Rutendo. Rutendo, in the WHO, you look at substandard and falsified medical products, and Minister is speaking to us about safety. Can you tell us, how do you use data to drive, to understand how you can ensure the safety of the medications that are being deployed?
Thank you very much. So my name is Rutendo. I'm with the WHO headquarters. I'm leading the team responsible for market surveillance and control of medical products, and this includes the medicines, your vaccines, as well as your diagnostics. When you're looking at a product, there are three main aspects that are linked. There's the quality, safety, and efficacy. So good quality product leads to probably a safe product, and also the product will be effective. But I'm going to focus more on substandard and falsified medical products, where there is falsification of the products, where there is substandard product, also because maybe there's poor manufacturing process or poor control by the distributor or the manufacturer of the product. we always talk about health data being a tool for innovation, but one of the aspects that we realize is that we are forgetting about data which is urgently required. And this is information on prevalence and incidence of substandard and falsified medical products. It's not just regulatory data that the regulators need to do their work, but it's also health data, and this is my proposition. It tells us where treatments are failing, it tells us where patients are being harmed, and where trust in health system is actually being eroded. So as WHO, and I'm coming from another session where people were talking about 1 in 10 medicines in low-to-income countries are considered to be either substandard or falsified, and others were showing data which is saying 30-40% of products are being are considered to be substandard or falsified. So it's a warning. Mm-hmm. It's a warning. So these products cause treatment failures, adverse reactions, and actually, in some instances, they might lead to deaths, especially for the vulnerable children and elderly. They contribute also to antimicrobial resistance. So the economic toll on of substandard and falsified medical products is very high. Our estimate from 2017 at least was countries are wasting more than $30 billion per year on procuring products that really don't work, are potentially dangerous, and also, for antimicrobial resistance, formerly treatable infections are no longer being treatable. Also, it could be attributed to substandard medical products. So we have data at WHO. We are collecting it with the national regulatory authorities. We issue alerts. We just issued an alert yesterday about contaminated medical products, cough syrups, which the children should not be having anyway. So we're strengthening surveillance, but we need to go further. Mm-hmm. In many low-resource settings, the burden of substandard and falsified medical products is very high, yet the data systems are weak. So strengthening these systems is something that we are looking at as WHO. Substandard and falsified medical products are really in the pharmacovigilance sphere. They reflect clinical outcomes, they drive service utilization, and also they impact health indicators like disease burden and mortality. So we have a monitoring system that WHO has in place. We use it to quantify the harm caused by these substandard and falsified medical products. We also use it to support any need for risk-based market surveillance, but truly to protect the patients, we must treat this data as essential health data so that it can be collected, analyzed, acted upon with public health frameworks. Mm-hmm. So we have 3 pillars that we work with: detection, prevention, and response. So these are the 3 main pillars. Now, you need to detect the products, and some of the things that you're looking at is the technologies to be able to do that. Mm-hmm. Laboratories are very costly, so you need to have technologies that can be used. So we identify where the prevalence is high, so we support the use of innovations, either to use machine learning to actually read labels which have been falsified. We need technologies which create libraries which can be used to scan a product on the field. We also need to, there's a lot of product which is being sold on the informal market. And we have recognized that by informal market, in this instance, I'm talking about the internet and social media, we need technologies, artificial intelligence, to go there, listen into social media, read the newspapers, and see what is being said. And all this is from actually identifying where the prevalences are high. And then we use the technologies or the innovations to be able to prevent, to detect, and to respond to that. So really, in order to transform care, healthcare, we must include data that that protects patients from harm, and this is what we are looking at as WHO as essential health data. It must be captured, as I said, mm-hmm. and this is one of the problems where countries don't tend to report. But when it's reported, we need to be able to analyze that data it can be big data, especially for medical devices. So we need innovation to be able to analyze that data and actually inform decisions that are made by the regulatory authorities.
Mm-hmm. When I listen to you speak, I hear that the importance of countries themselves being able to collect that data, because that is how it ultimately ends with the WHO. And you also mentioned that countries are not necessarily always collecting this data. What are some things that need to change to enable countries to collect this type of data regularly, so that by the time you're talking about, it is not about response, it's really about prevention?
Mm-hmm. So one of the things is awareness of the scope, scale, and harm that these substandard and falsified medical products cause. So awareness of the public, awareness of the healthcare professionals, and once they are aware, they will be able to respond to this. And the most important thing is for them to know that they are empowered to report. Mm-hmm. And this is, again, where we need to use innovation, having paper-based forms, having toll-free numbers to call. People don't have the time. But almost there's a high penetration of technologies, for example, your smartphones. So having smartphone apps that people can use to report about anything in the healthcare sector. You don't have to have an app for adverse drug reactions, for substandard and falsified medical products, complaints against the health practitioner. If you have one app which is sending a message to the ministry, for example, on anything, and then the ministry can then sort out the information. And again, this is where we need technology, because you will have hundreds, if not millions, of complaints coming in, and you need to risk assess them, and use of technologies to be actually to do the risk categorization and being able to parcel out the people that can make the decisions.
Okay. Professor Heyo, I read this morning that the university hospital was founded in 1710. And I imagine in those 300 years plus, you have collected vast amounts of data in many, many different ways. I think it makes you uniquely qualified to speak to us about how health facilities use health data.
Well, thank you. We've been founded 300 years ago. We're still there, but most of the data we have are, of course, on some kind of paper and not useful anymore in these days. So I think the value of health data, aside from recognizing them, as my three speakers before me really indicated, first step was to really recognize the value of that. And the other thing is now to address this central challenge and find a way how to turn information into really better care and stronger systems. I think we all agree that data are a major strategic asset, a key for clinical quality, operational performance, and innovation, because they allow us in a large hospital to deliver personalized medicine, tailored diagnosis, and at the end of the day, improve clinical decision making. In Germany, this is not an option. It's absolutely mandatory. I keep on telling that without much response. We will lose 30% of our workforce to retirement within the next 10 years. So it's not a question whether we digitalize and use AI or not. It's simply no way around. So we have to do that if we want to keep the standards of care in our country. And what we need to create, therefore, is a learning health system that is able to adapt and improve in real time. One of the key issues in working with data, from my point of view, is networking. I'd like to give you a practical example. When COVID came, I guess every government in the world was really afraid of that, also the German federal government. And they called us and asked us to form a network of all German academic medical centers. The network University Medicine, which was formed in a couple of weeks, was really successful in fighting COVID and is now still there. And a major point is, between in the meantime, 37 academic hubs in Germany, being able to exchange data in the widest sense. So we can exchange information on radiology. So if you have a specific question to a specific disease, you can get the information of all medical centers with that. So aside from collecting data, as you said, at the individual side, I think the interaction with other the institutional interaction is extremely important. This thing was evaluated after a little while by people from the US and England, and they told us the outcome of the evaluation was twice. One was they never thought that anywhere in the world you would get a network of all academic medical centers under one construct. And the second thing was the last country they thought this would happen was Germany. And so we still have that, and we really advertise that. And the next step then, I think, is data exchange with hospitals and institutions at other countries. And I would like to give two brief examples. Our anesthesiologists collaborate very strongly with partners in Uganda and South Africa. So we have these robots which you can steer out of Berlin from Charité, and they can walk. The robot can walk with a doctor at those both places in an ICU, go to a bed, look into that, and discuss among physicians what the best treatment is. And the other thing we are really involved in is interaction with Ukraine. We have a Solomia network there, which supports mental health and emergency. I think the entire mental health situation in countries which are under high pressure is a completely underestimated issue. And we try to do that in particular by telemedicine. And with this approach, you can reach really many people. So we have reached 20,000 patients and 100,000 people supported through digital mental health services. So in conclusion, it's pretty clear that data is a core driver of innovation, and at the same time, we should not forget that it's a main driver of responsibility, of interactive responsibility, and the value depends on secure use, clear governance, and a strong collaboration. And we, of course, think that hospitals may play a major role in this entire setup. And I think there are specifics to think about in interactions with countries with other structures.
And you mentioned collaboration, and I think collaborations are hard, just generally thinking about collaborations, but particularly collaborations that include the exchange of data. There are so many questions around data governance and data ownership and complexities around that. What can you tell us about the collaborations that you've had? What has made them successful? And are you able to share data across those organizations? And then I have a second question. And when we think about innovation, Bernd spoke about starting with the end in mind. You spoke about robots and robots interacting with the physician. What do patients think when a robot comes to their bedside? Is that something that they are comfortable with? Would they prefer a person? What is your experience?
Let me start with the last thing. There's never coming a robot alone. Okay. There's a doctor, a local doctor, and we do that with local hospitals around Berlin as well. So there's a human standing at the bedside, and aside from him is somebody who looks a little bit human and kind of offers the advising physician at the other place a very good picture of what happens then. You get all kinds of data in that. So I would like, because of the data sharing, which is of, in particular, importance, if you have countries who are differently organized, or if you have countries where one of them is a lower middle income country. I would like to make one point which really kind of puzzles me. I had a discussion yesterday morning, and there was somebody from Smart Africa, impressive organization, and he said that about 50% of the people who live in that continent don't have access to real healthcare. So how can you get there? How can you get that done? If you think what happened in Europe was we have huge buildings and we try to digitalize them, which is often a problem because the things originally have never been built for digitalization. So if you think about Africa, there are some things like these tools which are much more in use, and their phone systems which are simply much better than in our country. And if you look at the amount of medical data you get out of one of these devices, I think it's really a useful thought thinking about building a retrograde system, which does not start on buildings like in ours, but starts on digital data. And I think if you would start such a retrograde system, then our countries could really learn from Africa how to do that. Because the amount of data you get today out of digital devices will certainly replace lots of the hospital activities we have now. And if you see the rapid increase in censoring, we can talk about that through this discussion. I think this is kind of a unique opportunity, just doing it the other way around and giving by that a real example for others.
Mm-hmm. I'll come to you, Dr. Bettina. Can you tell us what is happening in Denmark? I think there has been a lot of progress in data use, data collection, particularly around genomic data. Please tell us a bit about what is happening.
Yes, thank you for the invitation, and it's great to be together with the panel here with the views from different sides. In Denmark, we have a long history of both digitalization, but also on collecting data and doing it nationally. So we have it from birth till death. A lot of registries. We have digitalized healthcare. We have it in hospitals. We have it in primary care. So what we are focusing at the moment is actually to move it forward, because we still have data silos. So we have within the country data silos, so we cannot, for innovation, allow people to get all the data. So for example, across hospital in different regions, they're not allowed to pass data through. So that we are working on it in terms of legislation, and also, of course, in trust, because one of the things I think is very important for all of us, no matter what country we are in, is to work on the trust of patients and citizens for the use of data, for innovation, and for performing a better healthcare. So that we have been working a lot about in Denmark. And I mean, I think also looking at this at a global level, we have a lot of data for high-income countries that are more or less, better, and the same, of course, in Denmark. We have pretty good data, but I think we also need to be aware that some data are not the same quality. We need to figure out how do we do that. And from my perspective of being in leading the Danish National Genome Center, there has been a lot of collaboration across Europe, but also across the world, in order to how can we actually standardize data, how can we collaborate, how can we do networking in order to better understand what we are doing. And maybe we cannot exchange data, as you said, but maybe we can exchange information of data, or figuring out how can we work together on the data in the different settings. So I think there are different perspectives to this, and I think it's very important to be aware of both, of course, moving your own country forward in terms of getting better access to data, or breaking down silos, and also building up infrastructure so the data can actually flow. Mm-hmm. But this morning we discussed how can we actually also maybe work together with Germany in order to better, figuring out how can we maybe in smaller bits try to exchange knowledge and data, and maybe we should not start too big, but start in the small, because before Europe and the international community get there, it will take several years. So we need, all of us need to move forward in the way that we possibly can. Mm. And then I think that the ones that has been moving things forward, we need to, learn by examples across countries. I know culture is different. So one thing implemented in one country can maybe not be implemented in another, but maybe part of it can help one another to move things forward.
Mm. You mentioned something that I think is critical. You talked about trust. And I think in the environment, in the era that we live in, trust and data are two things that we speak about a lot. How do I trust the data that I see when I go to our website, when I go to social media, when I hear something in the press? How do I trust that that data is accurate, is correct? And we are seeing also the way trust is shifting in who do we trust? Do we trust a government? Do we trust influencers? Do we trust technical subject matter experts? Who do we trust? And I wonder if in Denmark, what are you seeing and how do you build trust from your citizens in the data that you're using to create innovations?
I think that in Denmark we have a population that has, because we have the long history of collecting data and national registries, and also because we have a lot of trust in the population, both for healthcare but also for the authorities, we have been able to, actually move the field forward. But I know that influencers and things, may blurring that picture. So of course that is something that you need to be aware of. I think it's important both for healthcare organizations but also for authorities to keep working on communication about data and how data is being used. And in Denmark we have actually a way of looking into your own data that makes it possible that only you can look into real healthcare data. I think that is one thing. So that is on the personal level, and then it's also very important that by communicating that you use healthcare professionals, and that's another thing we learned by the COVID, probably also across countries, that when you have a crisis, you need to have experts communicating. So not only the authorities, but also experts communicating about the use of data and how data should actually be interpreted. Mm-hmm. So I think it's not easy, but it's very important to keep working towards it and working with the citizens and the patients on trust. Mm-hmm.
So before we go into our discussion, I wonder if there are any questions for our panelists, any comments from the floor around this topic of data driving innovation, and if we let it, how can it help us? Yes. There's one coming from the back.
Thank you very much for the insightful discussion. I was glad to hear, and you also highlighted the data silos that we have. And we need to break these health data silos, but health is also shaped by many other determinants, such as environmental, social, economical, and so on. And even though the European data space is a good approach and a promising step, but how can we also move towards a global and cross-sectoral data spaces so that health is tackled not just from the clinical data, but also in a more comprehensive aspect? Thank you.
Okay. Thank you. Anyone? Any other questions, comments? Yes, there's one here at the front.
It's you.
Yes. But should I answer?
Oh, sure.
Yeah, okay. So from my perspective, where I've been sitting and what you are answering, for example, we are trying to make a reference genome across countries, and that is at the European level, where we collaborate. So each country actually contribute to a kind of data set that we could use across borders in order to, when you do diagnosis and use the genomes and the variants, you can actually use these. We are not there yet, but we have committed ourselves to do so. And that's what I meant by, I think it's very important to have these international networks, both at the European level, but also totally international, where we also at the genome level work across Europe. There's just been a meeting in Sweden, where most part of the world participated, and one was discussing these issues. So I think it's important to work across and do networking in order to work across countries.
Yes.
Yeah, thank you so much for this wonderful discussion. My name is Justice from Robert Koch Institute. I want to ask more, somehow related to the previous question, more in the line of integration and as well as interoperability. So these days we have lots of data as we've already established, but how can all this data be pulled together? And you mentioned about accuracy, correctness, timeliness, because this is very important. So if we are getting data, for example, trying to solve a particular health challenge, and we didn't get it in timely manner, it will become useless. Even if we come up with some fantastic analytics, it will still not solve that problem because it wasn't gotten at the time it's supposed to be, collected. So in terms of data collection, I know in Africa, for example, there are still some places that internet is not very strong. So even if we have mobile devices, there are still, challenges of transmitting this data. So in terms of integration and interoperability to make these analytics to come up in a very timely manner that it can respond appropriately to the intervention or whatever we want to use it to address. How can we address that? I mean, from that perspective, looking at the integration and also interoperability. Accessibility is also another thing I wanted to ask about, because there are we have data, but sometimes it's very difficult to access this data, even for research purposes. We hear that there are open sources, but before you can even access this data, it's also very difficult. So maybe I've made a couple of points, but maybe if you can just touch on any of them. Thank you.
Maybe
I would direct that question first of it, Minister, about the how can you collect data at the point that it is happening, particularly for you where the situation, it is not easy to collect data. But I would also ask Rutendo. He talked about interoperability, about silos. I think that is something that we hear commonly spoken about, but I think it is more important where the data that you're collecting is coming from very diverse countries, maybe people speaking different languages. How do you ensure that the data that you're collecting can be brought together, can be assessed, analyzed, and then can be used effectively? Minister, shall we start with you?
Well, exactly. One of the most important things that I spoke about actually is while in crisis, try to collect data and manage accordingly. Because at the end, what people are waiting for is productivity. And this is related to the trust, how you build trust in data. When you have a problem and you solve it quickly and properly responsive in a short period of time, then people will trust you. And this is mainly the problem of trust and why is that necessary during times of crisis. One of the important things is to create a platform that is actively updated to a data hub or data center. And then you can guide your operations and guide your plans based on the data that you get immediately day by day. And all of us know that the response that we had during COVID times, where each day we had the updated number of cases, the spread, and the response that we were having. So this will create a channel of data that is daily updated and daily responsive and daily planned. At the end, what we ultimately look for is the result and the plan that is based on a solid data. The response, as I said previously, would be blind without data. But when you when you build it on solid background, the response will be proper. And this is the chain that maybe in low middle income countries like Lebanon, people are waiting for. It's a different perspective from a different side. maybe at another level we will talk about machine learning, about artificial intelligence, but realistically speaking, we're still at the level and the phase of having the registries, having the national data, planning our strategy, the national digital health strategy that we were talking about, and these are all integrated in one part at the ministry. Yeah.
Thank you for that. Indeed, I think in my area of work, we do have a lot of silos in terms of data, because when a country reports on substandard and falsified medical products, and by the way, it impacts both low, middle, and high-income countries. We get this every day. When a country reports on substandard or falsified medical products to the world, sometimes this is a barrier to reporting because they don't want to be seen as weak regulatory systems that they have in place. Whereas we are saying actually when you report it means you're actually being able to detect it and you can therefore prevent it. So we have indeed a lot of barriers with regards to reporting, and this is why you have silos between regions, between countries. In WHO, what we have done is we have what is called a member state mechanism on substandard and falsified medical products, which has been in existence since 2012. And this mechanism is one way in which countries can agree on how information should be shared. It has been slow. We are going through a process of reinventing the mechanism itself. But the idea is to try and get rid of these silos where information is not shared. And I think Justice did mention in his question, or made the comment that talking about data and access to information, and you were also asking about people, the first responders, the first people to respond to, at least in my case, substandard and falsified medical products having access to smartphones. So yes, indeed, the penetration of smartphones is very high, especially in low and middle income countries. But the problem is the cost of the data itself. So someone can collect the information, but just to access an app, download an app, it costs a lot more than you would ordinarily. So that actually is a barrier to data collection and also sharing that information. Indeed, one of the things that we need to work on is standards of how this data can be collected, uniformity of the data, so that you can encourage interoperability and sharing of this information. The problem is countries have got laws. Sometimes it's very difficult to change those laws so that you can harmonize. And this is, again, I think, where innovation comes in, where you have technologies that can actually read the different sets of information and pick up what is meant, whether it's language, whether it's maybe someone calls something falsified, someone calls it a counterfeit, and someone calls it whatever it is. You need technologies that will be able to read as if it was a human being to do that. And I think we need to move in that direction where there is innovation there.
I think I want to extend Justice's question, first of all, to you, Bettina, especially about what Rutendo has talked about. He talked about the importance of partnerships beyond the health sector, thinking about the telecommunications sector and policies that drive the cost of access to data. I don't know, because Denmark is fairly advanced in the work that they are doing, how do you bring in other partners to drive the results that you want as far as health data is concerned? And then I want to come to you, Band. I think Justice also talked about social determinants of health. And when I think about that, and I think about the medical devices that you are producing, and these innovations that are driving health outcomes, I hear us talking about health data. I don't know if we are also talking about the people who we are designing these innovations for, and how do we know these people? How do we know the users? If you're designing a medical device that will be used at a point of care in a health facility in Nigeria, in Angola, in Spain, How do you know who are these users? What is their context? How do I incorporate that data as I am designing the medical devices that I am designing? So we begin with you, Bettina.
Yeah, well, I'll try. I don't think we are perfect in Denmark. I'll just start by that. Because we just discussed a life science strategy this morning. I think we need to be much better in Denmark in order to do private-public partnerships. With that said, within our area, we in Denmark are unfortunate that we have the Novo Nordisk Foundation. And the Novo Nordisk Foundation actually collaborate with the government in order to support, for example, the Danish National Genome Center by building up the infrastructure, by helping the Danish government and the hospitals healthcare setting to implement new technology and collect data. So from being there for the last 5 to 6 years, it wouldn't have happened if we did not collaborate with the Novo Nordisk Foundation on that. I also think that some areas that we collaborate with private industry, for example, on developing, now we are here with Siemens and the imaging areas that we've been collaborating together with academics, hospitals and industry on, for example, implementing kind of AI or digitalization, for example, of breast cancer screening, where you have, a company going in helping academics in order to develop that. So that's the way that we develop it at the moment. So it's not easy like it has been in other countries where, for example, England with Genomics England, they are, collaborating with industry, letting them, let data get better, and then let both the public and the industry use the data. So that's another way of doing it. But I don't think we're perfect in Denmark. We are trying and we want to be better, but we're not there yet.
Bernd?
So maybe starting with, there's very different use cases of how data or healthcare related data, I'm going to say, can have an impact. There's process-related aspects, like the speakers have been spoken about, where probably the machines themselves generate data so that you can learn about processes, and machines can kind of learn themselves if you just can collect enough data. But I will openly say, that's not a field we are so much in. We are in the field where ultimately the users of these innovations are healthcare professionals to serve patients, ultimately. And in this, I can only say, the collaboration between industry and academia and healthcare providers is so key, so that, of course, we need to know and want to know what are the right innovations in the hands of healthcare professionals, be it operators of technologies or radiologists or clinicians that directly treat patients. We need to understand their daily jobs and how can AI and digital tools help them to do the job better or more efficient to improve patient outcomes. And in this, I will say, we spoke a lot about how data should be collected. Yes, I think there needs to be an ultimate framework of how can data that is generated be archived so that it can be reused at the right point in time. But the other aspect is also, how do you define the use cases that make a difference? In this, a lot was spoken about the non-communicable diseases. The major ones, 4 to 5 people die of one of those: heart disease, vascular disease, cancer, or neurodegenerative diseases, or stroke. And along those lines, I think innovation can be very much directed at what is the problem you want to solve, be it in precision of personalization of therapy, or be it in efficiency to enable more access. And this is then where data can be targetedly collected in a curated way, or maybe retrieved from already collected data with the right question in mind. Because this is, when you think of healthcare AI in the hands of healthcare professionals, that's at least how we as a medtech company look at it. Ultimately, the machines learn from human beings. The big difference is human beings also learn from human beings, but in a finite number, like on conferences or education. Machines can learn from indefinite infinite numbers of people who made decisions that can be collected. So that's how we like to look at AI, that it's the consolidation of this good decisions that were made by human beings, but thousands or millions of them, that makes those machines smart. And this is how we try to look at what AI can make as a difference in specific clinical use cases and ultimately help transform. And maybe I can hand to Hajo Krömer, maybe also for the collaboration between industry and academia to ask the right questions is key.
Yeah. Well, I think the interaction part is one which is extremely important, like you said. Aside from all technology, this interaction is mostly based on interpersonal trust. That's something which develops over time, and we should not estimate that too low. The other thing I would like go on something what Rutendo said, that the amount of data transferred is costly and thereby limits the availability. And you said in your introduction that 93% of all medical data are unused. I think we should really give thought what kind of data we use. So I have one of these watches, and it measures thousands of medical data. Probably they all go to the west coast of the US. But to assess my health status, you need a minimum of them. So I think one of the important things of the future will be to agree on something like 10 or 20 variables which you can readily access by censoring, that should be feasible, and keep it to that, so that the amount of data you have to transfer to assess somebody's basic status can be really low. And then I think it should be feasible to transfer these things also on low cost. So I think we're all fascinated by the things you can measure, and we should kind of restrict it, because they're really from a watch like that, you get life-saving data. Okay, if you have a non-symptomatic atrial fibrillation, it can cause a stroke readily, and you don't feel it, and maybe your doctor sees it after 6 months. The watch sees it after 5 minutes. And if we could really focus together and internationally on a set of data which we really need to keep something like 80 or 90% of the population healthy, and Bernd Ohnesorge took off on all the cardiovascular part, which is readily accessible by sensors and by cheap sensors, which are everywhere available, I think we would make a big progress. So it's a combination, I think, of trust, first part of the question, and the other part is being really selective of what we want to know.
I see there's a hand on this side. Yes.
Thank you. Good morning. My name is Aras. I'm from Kurdistan Health Summit. I'm the president of Kurdistan Health Summit, and I'm also the member of Pavia University delegation from Italy. So I have 2 questions and 1 invitation. The first question is for Prof. Hajo. So you mentioned that the data on papers no longer benefit. And you have also mentioned that you are going to exchange data across borders with the countries. Do you think that there are any restrictions on sharing data? Because in Kurdistan, they always talk about the relationship between data and national security. So are you going to share all your data, or you have also restrictions? The second question is for Dr. Rakan, the Minister of Health, of Public Health. So because we have like cultural similarities, political similarities between the 2 countries, do you think that we have to have restrictions on data to share it with like academic institutions? Okay, so we have in Kurdistan, as a part of Iraq, we have data on papers. Unfortunately, we don't have an electronic system to keep data up. And lately, they've told me that I've asked for data of 35 years ago for a PhD project for Pavia University, and they've told me that we have banned the files and the papers of these data, because according to the law, we can ban them if you don't have space to store them. We can ban them if they are older than 30 years. So, you know, I'm talking about a disaster of data. The invitation is, I will invite this panel, all of you, to the upcoming Kurdistan Health Summit taking place in Halabja, a newly recognized governorate, northern Iraq. It's a very nice place. They are famous for delicious food. And imagine their hospitality. They don't have hotels in the city because they think that they have to receive their guests in their homes. So they think that it's shame to have hotels. So I invite you all to that summit, Kurdistan Health Summit, even if it's virtual, although you are welcomed in Halabja. Thank you.
Thank you. I think we can take one more question. I see this hand.
Hi, my name is Shahid Yusuf. I represent a company in Pakistan. I may have a comment, and maybe you can consider that as a question. Rutenda talked about substandard products getting into the countries. At the end of the day, whatever we are trying to do, we're trying to improve the life of a citizen, make it easier for the government, for the businesses. My question basically is that having gone through these processes, we've realized that the standards through which those products can be actually sent to different countries are so varied that it actually delays the process. It delays the import of those sort of medicine. So I think before even we talk about data sharing, I think we need to talk about the standardization so that it doesn't become that difficult for things to actually move forward. Now, coming to on the data side, we've been working on this for the last 14 years, and our basic thought process was that the entire government system itself, from lady health worker to community wife to the doctor to the hospital, needs to be in an integrated form. And so we've been doing all that sort of stuff. And we've been actually testing various models. The biggest thing I think that we also have to realize that this brings accountability. It brings, a transparency on the system itself. And the human factor is that people don't want accountability. They don't want that kind of transparency which actually looks at their performance. The second part is that we also have been working on predictive models. We have created an app which basically takes the basic information about a pregnant woman and based on the genetic history and physical information and few other information, can guess if that woman's pregnancy is a normal pregnancy or is going to be a critical and must be referred to a doctor. Now, it took us a very long time to actually do that. This is the only app in the world which does that right now. But the reluctance on the part of a CMW is that if I use this, I'm going to refer my patients to a doctor and lose business. So I think those human factors, besides this data transformation, have to be looked at carefully. And I just wanted to get an answer or an experience from you. How do we actually overcome that part of it to actually implement something which is actually going to benefit both the person and the system itself? Thank you.
Can you pass the mic to the lady behind you, please?
Thank you. Hello, my name is Aru. I'm a medical doctor from Egypt. And I have a question regarding the innovation part rather than health data. So assuming that we have the health data and we have incredible innovations all around the world, which I'm sure many of them happen to exist, but some of these innovations do not belong only inside the hospital. They're actually in the hands of the people as we're walking. They are in the mobile applications we use. You have wearables, and the technology is absolutely unlimited. So when it comes to that, when patients have access to these innovations, their health-seeking behavior change. They have access to knowledge. And when they have that knowledge, they go to the hospital with a renewed mentality. They are empowered. They know sometimes they know exactly what they have. And the relationship between the patient and the doctor then is completely changed. Mm-hmm. So I want to ask about this perspective, like, what do we expect of innovation and its effect on health system later on, and the interaction between patients and doctors, and how they access this information, and how through this information they can actually receive the medical care they need, either elsewhere. They can go do the test themselves. If you have a health system that is unregulated completely, I can do a CT scan if ChatGPT tells me to do that, and that happens in my country. So I want your thoughts about that, and thank you.
Yeah. So I think we'll begin with the last question and move forward. I think we ask you, Heyo, what are your thoughts about that? Because you're in a hospital, I'm sure you see patients who already know what their condition is before you speak to them.
Well, I think that's very variable in a hospital, and I thought the question goes to Bernd because it was very clearly a diagnostic question. What this general issue, how to make the right selection for the right diagnosis, is something that's as old as medicine. And I think, again, by the information we have now, having a digital suggestion towards what happens next to the patient will again improve this thing. And at the end of the day, you will have a situation where you get a vast area of suggestions by AI. It's less related to an individual decision, and for that things may change. But I mean, you ask a fundamental question, and I'm not really sure whether it's at its basis solvable. And maybe Bernd Ohnesorge, who lives on that, can give a point in that direction.
I can try. It's a great question. I mean, and I answered on one angle from a professional perspective, and from the other, maybe from a personal perspective. I mean, all of us is once in a while a patient, hopefully less than more. We are mindful and responsible about knowing how we give these technology as tools, and I mean, there I have a bit of an easy answer from what we do as Siemens Healthineers. We tend to do innovations and give them in the hands of doctors or operators, so that they can also still and understanding that there's a patient behind that they interface with. And we believe that these technologies improve communication because they visualize, they make more fact-based, and to find a common understanding between physician and patient in the dialogue, and so that's definitely of help. In the direction of it's a cultural change or a mindset change in the interface between physician, medical professional, and patient. It's a challenge. At the same time, I believe it's a great challenge to find a way of participatory healthcare, so that patients understand they're part of the process, and it helps making the right decisions and the right treatment to understand of what am I thinking of what do I experience, how can I support in the process of giving information and data. And at the same time, physicians have to understand that there is a responsible human being in front of them versus an object who I tell what to do and he or she will do. So to elevate that interface, but will ultimately improve healthcare, that I'm pretty sure. And of course, patients should refrain or should listen to what their consultants and doctors have to tell them. But that, as repeating, the participatory eye-level elevation of that relationship will ultimately improve healthcare.
I think, Minister, the question from Kazakhstan.
Yeah, Kurdistan.
Thank you.
Pakistan.
So basically, the scope of discussion was initially regarding data collection and making sure that we collect data during crisis and have our data hub or data center actively working while in crisis to plan our management and plan our decisions. Now the question is more about use and abuse and what are the limitations that we have. Definitely, it's not a piece of cake. It's a challenging process in developing countries where you need the infrastructure, you need the digital the servers, the network among the hospitals, the health information system to collect all data and connect it basically to the central data hub at the ministry. And this is here our partnership with academia and with organizations, and then I'll come to the data use. So when we collect data from academic institutions, from medical centers, and collectively have this information, I believe that this is a mutual and complementary. It's our duty to pay back and help academia benefit from the opportunity of the central data that we have. And this will help us also plan our decisions based on academia and on capacities that we lack at the ministry. But I believe this should be controlled in a way where under the umbrella of the ministry, because we're worried about abuse, about pharmaceutical company interventions, about economical switches that can happen with abuse. So we try to, for which we have raised now a new quote-unquote advisory to the ministry named Digital Health Advisory, and we're activating back again the national cancer registries to control this and go case by case. Mm-hmm. Sometimes we even publish data from the ministry. Mm-hmm. So for example, during the last war, a recent paper was published in a Q1 journal from the ministry regarding the casualties, the types of injuries, and involving academia. So it's a complementary thing. Definitely no data should be lost as what happened, and we'll try to. This is a problem maybe with the system, and this is challenging issue, but definitely the complementary part is crucial. I look at it as an opportunity to involve more people and get them more into podium to make the decision with me, instead of like being defensive and protecting myself from people not sharing the data with them. So this is the political part behind it, if I would say. And we'll see you in Kurdistan.
I want, there was a question for Rutendo around standards and how standards sometimes can stand in the way of access.
It's a very difficult question to answer. WHO and other international organizations, particularly considering the fact that the role of WHO in a lot of instances is norms and standard setting. So we have, as much as possible, identified norms and standards that we recommend should be used by the member states. It's the implementation part which we cannot impose on the countries. There are some health regulations, for example, when it comes to emergencies and public threats, but harmonization is very difficult, particularly when countries have sovereignty over what they can do and what they cannot do. So it's a very difficult process, and it's very difficult for me to actually answer there, but we are trying as much as possible to make sure that countries are collaborating, particularly when there's a lot of cross-border trading, and we are encouraging countries to make sure that at least harmonization by using the same tools. We are using a process of benchmarking regulatory systems so that it's a way for us to harmonize, and hopefully that will also encourage the countries to work together.
Okay. I think, Bettina, you have a comment.
Yeah, the way, I mean, countries are different, and I know that some of you work on the global level. But in Denmark, in order to get, different data owners, if you will say so, from the different silos to report into the national system, we have legislation. So in Denmark, we have legislation that, for example, genome should be reported into Danish National Genome Database if it was performed in healthcare. We also have in surveillance of infectious diseases that, certain microorganisms found in laboratories or AMR resistance or something should be reported in. And then we have the authority, being in charge of that these data will benefit both the government, but also the international society. So for example, preventing infectious diseases, data are collected, and it's, for example, reported both to WHO, but also to the European Center of Disease Control. So I think that in Denmark, the government had actually the legislation in order to make hospital settings or healthcare professionals to report in the data to national databases, and that is then further, distributed to whoever it needs to be distributed. So that's the way it's handled in Denmark.
So we have 4 minutes to go. I see we have so many questions. We don't have time to take them at the moment because I want to give each of the panelists an opportunity to tell us in 30 seconds or less what next. We have discussed a lot about data, the opportunities that data gives us to innovate. And when we talk about innovation, we're talking about problem solving. We know that there's a lot of data, both digital and paper-based data, and maybe even in many other media. How do we consolidate, use that data? How do we take the things that we've been discussing here, the opportunities that data gives us, how do we take that forward? And I will begin with you, Bart.
So, first, I think we can assume or can build on, data will trigger innovation. I think this is a set. And I'm saying this because, I'm still looking at the headline. I kind of finish where I started. I think we have to read this from behind because the way it's written, from data to innovation to transformation, and we let it, it sounds like it's a self-propelled process. It is not. I think we have to take it reverse. We have to lead it, the transformation. We have to break down what global healthcare transformations and what are the specific pathways and clinical or access challenges we want to solve. And then, what are the innovations we need? And then we look for the data that is there or curate the data and collect it that is needed to trigger this innovation. So this is stepwise behind. And then I'm sure we will make progress step by step. And the how, we strongly recommend that around these questions, we build ecosystems, pilot systems that find themselves in collaboration between healthcare providers, academia, industry, to build these use cases and then to scale it. Be it in low middle income countries, how we find these use cases and scale them, be it in clinical pathways, address these specific areas and then scale them. So this is how I think we should move forward.
Minister.
Well, it's a transformation. It's not only a process, it's a mindset transformation. I believe that this will progress gradually. Maybe at the ministerial level, we can link it to other ministries at a national level than at an international level. At the end, it's a process ongoing, started by data collection, ended by decisions. Maybe now the process needs to be more active, using artificial intelligence. Now we have created a new ministry in Lebanon. It's an artificial intelligence ministry. Maybe that's a bit challenging in a country like a small country, low middle income country like Lebanon, but this is the mindset that we're talking about. This is how things should progress, I believe.
Rutendo.
Thank you very much. I think unlocking and sharing data responsibly will empower local action and global collaboration as well. I think from comments that colleagues have made today, I think what I'm getting is that health data digital harmonization and innovation is now. It should be done now. We must all embrace it, and we also must facilitate it in our different settings so that it can happen. Thank you.
Professor.
Okay, at Charité, we think we should scale up meaningful collaborations between high and low resource settings, use data and digital tools for mutual learning. We integrate device and population data into health systems and enable population-wide preventive and personalized care. And finally, we should focus on capacity building, interoperability, AI to use to really ensure sustainable impact.
Bettina?
Yes, I think it's important to build on networking internationally, collaborating, taking smaller bites, like some of you also said, in order to move the field forward, and then take concrete collaborations with in certain areas to make the use cases. So I think also that's very important.
Yeah. I think I'll close off by saying at the end of the day, when we talk about data, innovation, technology, we're actually talking about people. And people follow incentives, not advice.
Oh.
So what incentives can we put in place to drive not just the collection of data, but also the wide-scale use? And I will leave you with that question. Thank you very much. Please join me in thanking the panelists.